Hello everyone and welcome to my anatomy lecture on the renal/urinary system. So let's go ahead and get started right away. Alright, so here are the organs of the urinary/renal system. You've got here the kidneys, you have the ureters, and you have the urinary bladder. You've got the urethra. Okay, so those are the main primary structures found in the renal system. Now, they're not many structures, but they're very important. Now, here's a little key thing that you should know. A lot of students tend to get ureter versus urethra mixed up. And then, so one of the ways that helps me remember the difference between ureter and urethra is that ureter here has two letter E's versus urethra has only one letter E. If we look at our diagram here, there are two tubes from the kidney to the urinary bladder, but there's only one tube that leads on out. So if there are two E's, then it's called a ureter, right? If there are two tubes, that will be a ureter. If there's only one tube, that would be urethra. So something to help you guys remember. All right. So now what is the function of the urinary system? Well, it functions to help regulate electrolytes such as sodium, potassium, and other electrolytes. Also helps to regulate the pH in the blood, regulates blood pressure, blood volume as well, for example, by removing excess fluid, and also removes metabolic wastes such as urea, uric acid, and creatinine. Not to be confused with creatine, right? This has an extra IN in it, as you can see here. Now, removing metabolic wastes is the least important of the kidney's functions. You can survive for a few weeks without excreting waste products in the urine, but hour by hour, the other functions will end up becoming more important. All right. Now, the relationship of the kidneys to the vertebrae and the ribs, well, they are retroperitoneal and are located in the abdominal cavity. And they are at the level of the 12th thoracic vertebrae down onward to the 3rd lumbar vertebrae. And so they are at the costal margin, and the floating ribs help to protect them a little bit. Now, even though they are protected by the thoracic ribs, they are not in the thoracic cavity because they are below the diaphragm. As you can see here, here's the 12th thoracic lumbar vertebrae, 1, 2, 3. Here's the 3rd lumbar vertebrae, and the kidneys are located within that region, in between there, within those levels. And again, just to remind you, these are the ureters. Okay, they have the two letter E's here, so again, it is the tube between the kidney to the urinary bladder. And from the urinary bladder on out, there's that one tube, that's a urethra. Again, one E. Here's another view, a superior view of some of these structures here, so you can look at that on your own time. All right, now the structures within the kidney here, you've got the renal capsule, which surrounds the kidney, and these are made up of dense fibrous connective tissue. Now, a layer of adipose tissue surrounds this capsule, and these are called the pararenal fat or adipose tissue, and it helps to cushion and protect the internal organs. Now, around that is a connective tissue layer called the renal fascia, which is made up of loose connective tissue. It anchors the kidneys to the surrounding peritoneum and the abdominal wall. It is not very strong though, because it's not strong, it causes a jumping up and down motion and can result in tearing of the fascia. Now, back in the early days, like back before any of us were probably born, back in those days, there was a machine that was alleged to help reduce fat, and that was called the vibration platform machine. And as you can see here, a whole bunch of patrons are using this machine, and the idea was that it wiggles the fat away. Of course, we know now today that is pretty dangerous because it can lead to kidney damage, but it's quite amazing that these machines back then, compared to the knowledge and research that was done, that people had thought that this helped to reduce fat. Now beware though, if you were to go to third world countries, and you might see in some of their gyms some remnants of the past. These machines might still be found there, and again, beware when you go on these machines. Okay, it could result in kidney damage. All right, so here's the gross anatomy of the kidneys. You've got the renal cortex, which is the most superficial layer of the kidney. You've got the renal medulla, which contains the renal pyramids, which helps to drain nitrogenous waste into the calyx and filtrates into the calyx. And you also have here the renal pelvis, which contains the calyx, and then it drains into the hillux, which eventually leads to the ureter. And we also, of course, know what the ureter is. Here's a very nice diagram showing you that. As you can see here, we've got the renal fascia, which is on the outside that covers the kidney. You've got here the renal capsule, which is on the outside here. This is actually the adipose tissue that surrounds it. The renal capsule here is the outermost layer. And then you've got the renal cortex. And then you have here the inner segment, which is the renal medulla. And in here, these are the renal pyramids. And then here you are the calyx, or calyces. Plural is calyces. Singular is calyx. One calyx, many calyces. This would be the renal pelvis right here, this whole structure. And then eventually it empties out into the ureter. Now, this structure here, this is known as the interlobar arteries. These are the interlobar arteries. And then down here you have the interlobular arteries, and that you'll see that here. Now, the fundamental unit of the urinary system or the renal system is the nephron. We're going to talk about that in a little bit. All right, so here's a very much better drawing of those structures. Again, we have the cortex on the outer portions here. This will be called the renal pyramids, located in the medulla. And then on the outermost here, you've got the renal capsule and some adipose tissue underneath that. And then here is the renal pelvis. These are the major calyces on the outermost here. And then they collect and congregate down here in the renal pelvis. And then eventually those nitrogenous wastes will come together and then empty out here through the ureter. You have here the renal artery and, of course, the renal vein. All right. So here is the direction of blood, the pathway of blood toward the kidney. So you have here the blood starts out in the aorta. Of course, it goes through the heart pumps, and then the first vessel that this oxygenated fresh blood goes into is the aorta. And then as it goes through systemic circulation around the body, then it comes into the renal artery. And then finally goes into segmental arteries, goes into the interlobar arteries, lobar arteries, and then it goes into arcuate arteries, which forms arcs, and then it goes into interlobular arteries, okay, and then finally into the kidney. And then it gets filtered and it comes out here through the interlobular vein, comes out through the arcuate vein, and then we have the interlobar veins, and then you have the segmental veins, and then it goes out through the renal vein and then returns back into the inferior vena cava, and then finally into the heart. All right, these structures you can look at pause the video and you can review those different structures when you pause the video. All right, so now just like the functional unit of the lungs, the functional unit of the lung is the alveolus. The liver is the lobule. For the kidney, it's the nephron. Now, each kidney has around 1 million nephrons in it, and each one carries out all the various functions of the kidney. Now, the anatomy of the nephron includes the glomerulus, which is also known as the, which contains the Bowman's capsule. Bowman's capsule. You also have the proximal convoluted tubule. You have the loop of Henle, which consists of a descending portion, descending limb, which contains a thick and a thin region, and then it goes up through the ascending limb, which contains, of course, thick and thin portions. And then eventually it goes out to the distal convoluted tubule, and eventually the newly formed urine will start to collect. So we go straight down this list here. All right. This is a very nice diagram here. You can see here's the intralobular artery, and then the dirty blood, I guess you want to call it, containing the nitrogenous waste goes into the afferent arteriole, and then finally goes into the glomerular capsule, also known as the Bowman's capsule. Okay. Bowman's capsule. Okay. And then what happens in this first segment is that most, actually, if not, it starts to filter the blood. Now, when it filters out the waste of the blood, it doesn't mean that all of the filter that comes out will end up in urine. Okay. It's just like when you go trick or treating. During the holiday Halloween, you go trick or treating, and then you have a bucket of candy, and then you go from house to house and you collect all this candy, and you finally, after the trick or treating is done, you go back home and then you empty out that pumpkin of candy onto the table. And once you empty it onto the table, there's some candies that you really like to eat, and there are others that you really don't like to eat. But that's what the glomerular/Bowman capsule is doing. It's collecting anything that could possibly be filtered out from the blood that it doesn't need, okay, that it might not need. Now imagine now you have the table full of Halloween candy, and say that you're looking at all this candy and you say, you know what, I like fruit candy and I don't like chocolates. And then so what you do is you go through each one of the candies, and then you take out chocolates, go into one pile, colorful fruity candy goes into another pile. You're starting to sort them out. And then next, once you've sorted them out, then you go into each one of those piles and you say, you know what? Of the fruity candy, I'm going to sort out soft versus hard candy. Same thing with the chocolates. You start out, you sort out the Tootsie Rolls or something like that. Anything that's soft, you move out. And then anything that's tough and hard, then you move them onto another pile. And that's what's going on in the nephron. As it's moving, as this filtrate is moving down and across this nephron, it's starting to sort out different filter molecules and saying, okay, well, this molecule, we might want to bring it back into the body. Other molecules like urea, we might want to keep them in the urine, in this filtrate, and then eventually take them on out. So that's what's going on in this region here. It's sorting out that filtrate. Okay, just to review, again, we have the Bowman's capsule right here, and then it goes through the proximal convoluted tubule, and then eventually it goes down the descending limb around this loop, and then it goes up the ascending limb, and this whole region here is called the loop of Henle. And then finally it goes out here through the distal convoluted tubule, and then finally out through the collecting duct. Now here's the thing, as we are moving down toward the medulla, okay, so as a filtrate here, as a filtrate is moving across and it goes down the ascending loop, as we're going toward the core of the kidney, the salinity is much higher as you go down toward the core, and that affects the osmosis and the movement of molecules because it's so salty, really salty down toward the renal medulla, versus at the cortex it's not as salty. So it affects which molecules are going to diffuse across, affects the ones that are going to move out of the loop of Henle, and it's going to affect those that are going to go into the loop of Henle, so that will be very important there. All right, here's another image showing you that nephrons. You can see here the outermost is the renal cortex, which contains that Bowman's capsule and the proximal and distal convoluted tubules. But as it's going down and up the loop of Henle through the descending and the ascending limbs, it's passing through the renal, first the cortex and into the renal medulla, and then back on out. And the reason why is because of the osmotic pressure. It's much more salty as you get toward the center core of the kidney compared to the outer portions of the kidney, which is not as salty. Now another thing here, as you're moving down the descending and the ascending loop, the permeability, the permeability of different molecules changes. What I mean by permeability is that as you're going down the descending loop, that loop is saying certain molecules can get filtered out. But as you're going up the loop, then the loop changes its preferences. You know what? I want that molecule to come back in, but other ones to go out. So it picks and chooses which molecules it wants in the filtrate and which ones it wants to return back into the body. That's what I mean by permeable. So as you go down and up this loop of Henle, the permeability for different compounds changes. Okay, and then finally it gets into the collecting tubule and out here through that collecting duct. Now this is something that you would want to know. This is what the glomerulus/Bowman's capsule of the nephron looks like, which is very different from the islet of Langerhans that you find in the pancreas. You might want to go back and review your digestive system lecture and lab and anatomy and make sure that you really know the difference between looking at a histology image, a microscopic image of a glomerulus versus that of the islet of Langerhans in the pancreas. Okay. Oops. Okay, so the juxtaglomerular apparatus. Now the distal convoluted tubule passes next to the glomerulus to form the juxtaglomerular apparatus, and it consists of cells located in and around the glomerulus and the glomerular capsule. Okay. Now if the blood pressure is too low, then this apparatus releases adenosine, which causes vasoconstriction of the afferent arteriole. And that's when the blood pressure is low. And this will slow the filtration rate so that less water is lost and the blood pressure increases. Okay. Here is that juxtaglomerular apparatus, and again, it causes the vessels to constrict, so therefore not as much water is going to be filtered out. Again, water also gets filtered out into the Bowman's capsule. Again, like I told you guys earlier, it's not just nitrogenous waste that gets filtered out in the filtrate. We got water and salt and other different kind of electrolytes that the body actually might want to take back as it's going through that loop of Henle. Okay. Now, the blood pressure is still too low after adenosine has caused vasoconstriction. Then it secretes out a hormone called renin, and it causes more sodium to get reabsorbed so that the water follows it, and then the blood volume increases, and therefore the blood pressure increases. So salt will get retained in your bloodstream, and so therefore keeping the osmotic pressure high, okay, in there and causing the water to retain. Now that glomerulus is the first part of the nephron, and that's this structure right over here. This one here, that's a glomerulus. And that's where the filtration occurs. And that means that the plasma leaks out of the capillaries and into the convoluted tubule, more particularly the proximal convoluted tubule. Now it is located only in the renal cortex. You will not find the glomerulus in the renal medulla, okay, in the center core. It's on the outer edges of the kidney. Now, glomerulus here means ball of yarn. It is a tuft of capillaries surrounded by the glomerular capsule, also known here as the Bowman's capsules I mentioned earlier, and these are made up of simple squamous epithelial cells. Now, the capillaries fit into the capsule like my fist punched into a balloon, or I don't have a balloon on me, but like my hand, and it just wraps around that capsule. That glomerulus, I apologize. Now the capsule collects the plasma from the capillaries and then it drains it into the convoluted tubules, which empties into the collecting duct eventually, and then it exits out the body. And the plasma in the tubules has nutrients which need to be reabsorbed back into the blood, like I mentioned. Okay, so the plasma, just like trick-or-treating, you collect all the candy. Doesn't mean that the candy that you get is what you want to eat. Okay, and so you have to pour out all the candy and then you sort them out, and that's what's going on here. The plasma gets absorbed in. It doesn't necessarily mean that all of the nutrients or all of the plasma that gets filtered out is going to end up in urine. Some things need to come back into the body. Okay. Here's a very nice image of the glomerulus of the nephron. Now, normally at the end of a capillary bed, you have a venule, but this is only part of the body. This is the only part of the body that is different. Here we have another arteriole, and that's called the efferent arteriole, which takes the blood away from the glomerulus. Now it drops down straight next to the loop of Henle. While it is straight, it is called the vasa recta, which means straight blood vessel. And there are capillaries that come off the vasa recta which surround the loop of Henle. Remember I told you when it goes down the descending loop and around and then up the ascending loop, part of the loop, different electrolytes and different compounds gets filtered out and comes back into circulation. It's starting to sort out what it wants to keep and what it doesn't want to keep and what it wants to put out into urine. And so you have those capillaries that are wrapped around that loop of Henle, and these are called peritubular capillaries, and then they leave the area to become the interlobular lane, and which eventually leaves the kidney. And again, the filtrate gets filtered into this gets sorted out, and the nutrients that the body wants back goes into these capillaries and then back into systemic circulation. You can see this is a very basic diagram of that. Obviously it's not this simple looking, but this is the vasa recta. And again, as the filtrate is moving down the descending limb around and up the ascending limb, it is sorting out what it wants to keep, what it wants to put back into circulation, and then as it goes up, what it wants to put back into the urine, and then vice versa. Here's a nice model showing you those different vessels. You can see here is the afferent arteriole, and then as the blood gets filtered in the Bowman's capsule here, then it goes out the efferent arteriole. Okay, and here is a proximal, one of the convoluted tubules, and in this example, it is the proximal convoluted tubule. Now, the blood comes in from the afferent arterioles. Again, back here, blood comes in here. And then the plasma leaks out and enters the glomerular capsule. It contains nutrients which need to be reabsorbed back in, as well as waste products which needs to stay in the filtrate. Now, as the plasma moves through the proximal convoluted tubule, all the nutrients and most of the water and most of the ions are reabsorbed back out of the nephron and then back into systemic circulation. Now, in the loop of Henle, almost all of the rest of the water and salts are reabsorbed back into the blood, and everything that is not reabsorbed, i.e. waste products, goes into the collecting duct and eventually gets out and excreted as urine. Now, this is also how the water-salt balance is maintained, as well as the acid-base balance. The kidneys can remove or retain acids as well. I'm done with this image. I'm moving on. You can pause the video and review it. Okay. Now, in the distal convoluted tubule, we're now here in our journey. The rest of the water and salt are removed out, and then the rest of the liquid goes into the collecting duct. The distal convoluted tubule and the collecting duct fine-tune the water and salt absorption and excretion. If you are well hydrated, the water will be allowed to leave as urine. Now, if you are thirsty, the water will be absorbed, and the purpose of the peritubular capillary bed is to absorb these things from the nephron tubules and then put them back into systemic circulation so that your body can use that resource that it's looking for. All right. So again, here is in the interlobular artery. The blood containing the waste comes into the afferent arteriole, goes into the Bowman's capsule, the glomerulus, which eventually is here, the glomerular capsule. Filtrate comes out. Okay, this is known here as glomerular filtration because it's filtrate that is going into the glomerulus, and then the Bowman's capsule, and then eventually it will come out here through the efferent arteriole and then goes down the descending loop. Okay. As you can see here, this is not the descending loop. I apologize. My brain is not working today. Again, we have here a glomerular capsule, and it's going down here. This is the proximal convoluted tubule, and as it filtrates moving on down, you can see that we have tubular reabsorption where filtrates are leaving, and as it is needed, if the body needs it again, it goes back into systemic circulation, and then you have here tubular secretion, which is when you have compounds that need to go back into the filtrate and eventually leaves as urine. All right, this is a very nice zoomed in image of what's going on. As you can see here, we are now at the renal corpuscle at the filtrate membrane, And as you can see, we have these slits, and as the blood plasma oozes out, it starts to filter. Okay.
Reabsorption, electrolytes and nutrients move from the filtrate back into the bloodstream. Here also, through tubular secretion, substances move from the peritubular capillaries into the urine filtrate. The filtrate concentrates in the collecting tube. The nephron is the functional unit of the kidney and is composed of a glomerulus, which filters the blood, and a tubular component, where necessary substances are reabsorbed into the bloodstream and unneeded materials are secreted into the tubular filtrate for elimination in urine.
Okay, let's see here. There's a website link. Oh, nope. All right, let's go ahead and continue on. All right, diuretics. These are medicines that increase the amount of urine that is produced. And people who have high blood pressure might be prescribed diuretics in order to decrease blood volume. And again, if you have high blood pressure, that means you have a lot of fluids inside of your vessels that causes a huge amount of pressure in the vessels. So you are prescribed a diuretic so that you urinate more to push that fluid out. People who have high blood pressures might be prescribed this for that. Alcohol is a diuretic, and this is what contributes to the symptoms of a hangover. So the best way to prevent a hangover after drinking is to consume tons of water before you go to bed. What really works, that I know really works, I find water pretty boring. I like to drink green tea. Because water can get boring, but water's the best. A cup of water for every cup of these beverages in order to prevent yourself from getting dehydrated. Now, the proximal convoluted tubule is the next segment, and this area absorbs all the nutrients and 2/3 of the water and the salt. Now, only about 1% of the fluid that leaves the kidney capillaries. And then you have the reabsorption of different nutrients and water and essential ions that are reclaimed back in. And then you have the secretion, which is an active process of removing undesirable molecules, and eventually gets excreted out of the body in the form of urine. All right. This is just a more detailed image of the different structures that we were talking about. Okay, you can pause the video and review those structures on your own. All right, so the collecting duct here, these receive urine from the distal convoluted tubules. Okay, here is the distal convoluted tubule, and then it collects here. That's a collecting duct, and it empties into the calyx, which eventually empties into the ureter. Now, these ureters are long tubes that connect the renal pelvis of the kidney to the urinary bladder. Now, these ureters have a mucosal layer. This is made of transitional epithelium for expansion, and also has a lamina propria layer, which has elastic tissues in order to allow it to recoil. It also has a muscular layer made up of smooth muscle. It contains an inner circular muscle and also an outer longitudinal muscle. And it also has an adventitia layer, which is made up of loose connective tissue, and it provides protection and strength for the organs and attaches a ureter to the surrounding structures. Now, the urinary bladder is identical in terms of histology to that of the ureter, except that the mucosal layer has folds known as rugae, which allows for expansion, and that makes sense. The urinary bladder, when there's no urine in it, will kind of contract back on down like a deflated balloon, and then when you add urine into it, it's like adding air into a balloon. Those folds start to expand and allows it to hold more volume of fluids. Okay. The rugae have the same basic function as transitional epithelium, and it is accommodating stretch as the bladder fills, and so that means that those rugae are folds, and as the urine is going in there, it stretches on out and it pushes like air filling up a flattened balloon. You can hold up to 1 liter of urine on the average in your bladder, although around 500, just halfway, you're probably going to go nuts and start dancing. You really need to go, right? Okay, so here is an example of the urinary bladder. As you can see here, when it is flattened, there's no urine in there, it's very flat, and you can see that the inner lining of the urinary bladder starts to fold inward on itself, forming those rugae. And then when it is full, then it stretches on out here to the size of roughly around a softball. Okay. Now the muscle layer that makes up the urinary bladder is thicker than the ureters, and this is called the detrusor muscle, which contracts to allow the emptying of the urinary bladder. Now the function of the bladder itself is just to store urine so that you and I can hold our urine a little bit longer, so we don't have to be dribbling out urine as it's being made and as we're doing our daily activities. That bladder helps hold that urine in there. Now there are individuals who had their urinary bladder removed, and so they can't hold their urine, and they can't wait an hour or two before they can go, and so they have these apparatus, these sacs that they have, say for example, around their leg that collects urine as it's being made. Okay, so it's like having an external artificial bladder, but somewhere else. I've seen bladders that are wrapped around their leg, in their mostly I've seen the ones that are wrapped on the leg. Okay, here's a detrusor muscle right here on top. All right, now the ureters enter at the base of the urinary bladder, not at the top. So as a bladder fills, the urine presses down on the ureters to prevent urine from backing up into the kidneys. Okay, and you can watch this surgery. Copy and paste that link. All right, now we're at the urinary bladder. There is a region known as the trigon region. That's a triangular area where you get the ureters, and you also get the urethral openings there in that particular triangular region. Now, between the urethra and the urinary bladder, there are actually two sphincters. The first one is the internal urethral sphincter, which is made up of smooth muscle that you cannot control. And then there is the external urethral sphincter, which is made up of skeletal muscle. Now, although it is primarily under voluntary control, if you have way too much urine in your bladder, eventually it's going to give in and then release out that urine if you have too much. If the patient is in a coma or under anesthesia for a long period of time, then the internal sphincter will eventually be closed, like when you are asleep. So a catheter is needed to keep it open and in order to allow it to drain. Here is that trigon region. You can see here the ureters are right here, and then the opening goes around and right here, bam. Okay, same thing on the other side. And then of course you have the urethra here, all within this triangular region. Okay, the trigon region is all here. Now the internal urethral sphincter is in here. The external is out here. Okay. Now, here are bladder stones. Okay, these are example of bladder stones here. Pelvic ultrasound, I don't have that attachment. Skip that slide, guys. Now, the urethra here, its function is to drain the urine to the outside, and its histology is the same as the ureters itself. Now, in females, female urethra is around 3 to 4 centimeters on the average in length. Now, males, men, us, our urethra is around 20 centimeters in length, almost 5 times more the length of that in females. And of course, the length of that urethra varies with mood. Okay, so therefore women, especially young girls, are more susceptible to a urinary tract infection because the urethra is so short in length that the bacteria cells like E. coli, which is of course found in the gut, and the rectum is right nearby the female urethra, and so therefore there's a chance that E. coli cells could find their way into the urethra and cause a UTI. Men, we could get a UTI, but we must not have been urinating for like a very, 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 very long time for that bacteria cell to get in there. And usually it's due to other reasons. For example, a urinary catheter was shoved in there and the bacteria cells just came along for the ride, and then they found themselves in your urinary bladder. You could get a urinary tract infection if a safe protocol isn't followed for that. So, and the abbreviation for urinary tract infection is UTI. Now, urethritis is the infection and inflammation of the urethra. Pyelitis is the infection of the renal calyces. Cystitis is the infection of the urinary bladder. And cholecystitis is the infection of the gallbladder. Okay, so these are different. Cystitis is talking about an infection of the urinary bladder. Cyst is a medical root that means sac, and it just depends on how it's used in the medical field in order for you to determine, is it talking about, what sac is it talking about? Okay, in this example, if it says cholecystitis, then it's infection of the gallbladder. All right, let's talk urea. This is the waste product of amino acid metabolism. Okay, so remember that proteins are made up of amino acids. So amino acids are the building blocks of protein. So when you break down proteins, you break them down into amino acids, and then the waste product left over is called urea. Now, this is the main waste product in urine, and eating excessive proteins can cause kidney damage since their breakdown products are acidic. Now, when you urinate, it should be clear and colorless or almost no yellow in it, maybe a little bit. Now, the more yellow the urine is, the more dehydrated you are. And if the urine is very dark yellow, you're burning too much protein, as in food deprivation. So this is often seen in diabetes. If your urine is so bright yellow that it almost glows, are you taking creatine for body? Okay, so causes of renal failure. Again, medication, poison, infections, one. People with long-term health problems are most at risk to having kidney problems from medications. For example, antibiotics, pain meds, blood pressure meds, and even dyes used in x-rays. Sudden drop in blood flow due to a heavy blood loss from an injury, or maybe a serious infection or severe dehydration. Also, blockage of fluid out of the kidney stones, tumors, and an enlarged prostate gland could lead to that. Now, who is most likely to get renal failure? Well, those who have kidney or liver disease, diabetics, those who have hypertension, high blood pressure, heart failure, obesity, bone marrow transplants, those individuals who've had a bone marrow transplant, or even heart or belly surgery. Now, the symptoms here, there's either very little or no urine during urination. If the body is unable to excrete potassium, for example, the rising potassium levels is associated with ventricular tachycardia and ventricular fibrillation. And lethal injections are excess potassium. Okay, so that's kind of how individuals who are on death row, one of the ways that they do so is through excessive amounts of potassium. Loss of appetite is one. As waste accumulates, lethargy and fatigue become apparent to the point where mental function can decrease to a coma. Body weakness, okay, because of the low levels of erythropoietin that is produced by the failing kidneys, they don't stimulate the bone marrow, which leads to a decrease in blood cells. Red blood cells, this leads to less oxygen throughout the body, which leaves the body unable to do its work efficiently. High blood pressure / hypertension, because the kidneys cannot deal with the rising acid levels in the body, breathing becomes more rapid as the lungs attempt to try to blow off the carbon dioxide to buffer the high acidic levels. In doing so, fluid can be deposited in the lungs, possibly causing congestive heart failure. Swelling of the legs and feet are other symptoms. Nauseousness and vomiting, back pain, especially below that of the rib, known as flank pain, and there are even individuals who don't even experience any symptoms, and those individuals are asymptomatic. A means without symptoms. Symptomatic means pertaining to symptoms. All right, so the diagnosis. Patients can be diagnosed by undergoing blood and urine tests, and here are several different tests related to blood. You have the blood urea nitrogen test. There's a creatinine test, and the glomerular filtration rate. In urine, you can measure the amount of protein that's found there, the abnormal presence of white or red blood cells that is found in there, or even measure electrolyte levels. Patients can also undergo an ultrasound to see if there are any obstructions in the urinary pathway. All right, so the treatment here. If the individual has blood loss, well, the treatment here is to put the blood back, restore the blood levels. If the patient had poisoning or overdose or medication reaction to the medication, Well, then stop taking the med or the poison. If there's a blockage in the urinary passageway, well, get in there and remove the blockage, right? Or bypass the blockage if you can't remove it. Also, the person treating the patient will attempt to stop the buildup of waste in the body, and this may be done by dialysis. Now, the person treating the patient may also administer other medications to prevent the retention of excess fluid and the minerals and prevent any further renal damage. Lowering phosphorus levels, increase production of red blood cells, regulate blood pressure with meds. Now, the prevention here is through blood pressure regulation, sugar intake regulation, protein intake regulation, and even staying well hydrated. Once a kidney fails, the only option is through dialysis or to get a kidney transplant. Okay, these are the different tests. Okay, urine tests, different things that they measure. For example, normal urine should look clear. There shouldn't be any bacteria or bilirubin in your urine. The color of the urine should look very light yellow. You should have very few epithelial cells that are in there. Erythrocytes, low levels of or no levels of erythrocyte. You shouldn't have glucose or hemoglobin, and etc. etc. You can read down this list. This shows you what the normal readings for a urinalysis should look like. Oh, so what does it all mean? How to perform the test? Well, you have a strip, okay, or you have a cup, and then you have to collect the urine in the cup. Typically, they want you to collect it midstream. They don't want to collect the first few drops of urine because the urinary meatus, the hole that the urine comes out, at that hole there's tons of bacteria cells, and so they don't want the bacteria to travel along into the urine cup and then perform a urinalysis later. And so catching it midstream is much better, so that all the bad bacteria that they don't want gets flushed out, and all that's left is sterile urine. Urine is sterile, guys. Now, urine should be examined within 2 hours, or it should be refrigerated if not read immediately. Here are different tests that are conducted during a urinalysis. You can get the specific gravity test. In a nursing biochemistry class, I taught that a while back. This measures the urine osmolarity. It represents the patient's hydration level and concentrating ability of their kidneys. And normal levels should be 1.003 to 1.030. Okay, that's specific gravity. So they compare the gravity of two different substances. If you have increased levels of that could be indicative of glycosuria or glycogen in your urine. Or if you have lower levels, and that could be due to diuretic usages, diabetes insipidus, DI here, diabetes insipidus, could be due to adrenal insufficiency, aldosteronism, or even impaired renal function. A pH test, again, urinary pH reflects the serum pH, except in renal tubular acidosis, or RTA, useful for diagnosis, management of UTIs and caliculi. Normal levels are 4.5 to 8.0. Slightly acidic is usually around 5.5 to 6.5. If you have urine that is